Welcome to yet another episode of Innovation in Hematology Plus, uh, talking about immunocompromised patients. And Dr. Neha has been at the forefront in dealing with our infectious disease people and lightening the path for us to tackle these complex problems is not only the bacteria. We always knew about the bacteria, but how the funguses and the viral infections are taking place in people who are undergoing all complex kind of haplotransplants, the bite therapies, and the CAR T cell. So we would invite everybody to these infectious disease forum in immunocompromised series where we get enlightened from various speakers. And today we have a very eminent speaker talking about what should be our strategy to screen them. So without wasting much of our time, Dr. Neha has done a remarkable job in the country for CMV, as the publications are soon going to be there in the realm of CMV. So over to Dr. Neha, and I congratulate Dr. Neha for taking this initiative to enlighten all of us. So around 250 to 300 people every time joins across Southeast Asia, Middle East, and India. Thank you, Doctor, for sparing your time for us and enlightening with your thoughts. So over to Dr. Neha.
Thank you, sir. First of all, thank you to Dr. Malanis for really taking our time on this very much needed topic. So when we were discussing that, we always talk about the management of the infections in these set of patients. So it's always better to have a more prophylactic and a more preemptive approach. Because when we know that the newer therapies and the entire therapeutic landscape in oncology and hematology care has now been emerging more and more in terms of newer immunotherapies, CAR T has rolled in like a massive fire. Bone marrow transplants are happening with the proper allogenic transplantation mode. So in that perspective, it's always important to understand that what kind of therapies are being there and what kind of anticipated risks in terms of infection profile it is. Because no matter what, the infection still remains one of the very important sequelae and complications. So in order to further enlighten us, it's really my honor to introduce Dr. Marika Malanis. Ma'am has been a pioneer stones in terms of the transplant infectious diseases. She's a medical director at University of Philippines of Medicine, Nashville, US. And of course, she's the chair of one of the very, very important Society of Immunocompromised. I recently had a very much privileged chance to interact with her in the terms of transplant infectious diseases as well. So without wasting further ado, I would invite Dr. Marika to give us a great talk about how to screen infections in these hosts. Over to you, ma'am.
Oh, hi. Oh, I have to share my screen, Neha. Okay. All right. Well, good evening, everyone. I'm Marika Malinas, and thank you Neha for your wonderful introduction. So I'll be discussing today the screening of solid organ transplant, hematopoietic stem cell transplant, and CAR T cell candidates. Prior to the procedure, that can help us in strategizing their or mitigating the risk for infection. So I'll be mainly speaking based on the US experience. In the US too, there is a lot of heterogeneity in the practice, across centers, but there are some common themes that we do that is considered standard of care. And obviously, the epidemiology of infections may vary in different parts of the world. And, some of the things that we do are more on kind of targeting certain screening, but probably in India, it may be something that, needs to be like standard screening for certain endemic infections. So I have no funding related to this talk. And I decided to do a case-based approach because there's three aspects of this talk, just to kind of really, organize it. So the first case, is a heart transplant candidate. So at Vanderbilt, it is actually mandatory that transplant infectious diseases evaluate these patients, and that practice may differ in other centers wherein it may not be mandatory and targeting patients at higher risk for infections. So this is a 55-year-old African American male with non-ischemic cardiomyopathy, has an LVAD, and undergoing transplant evaluation. So other than his underlying heart disease, he has hypertension, diabetes. At that particular visit, he has no particular complaint. He has not had any recent hospitalization. He reported that he has a chronic driveline infection due to methicillin susceptible Staphylococcus aureus and maintained on cefadroxil suppression therapy. He has lived in Tennessee since birth and has traveled to other countries, including the Mexico, Caribbean, and Canada. Lives with his wife and 2 children, which are ages 10 and 12. Has a 1 dog and 1 cat. Works in construction prior to this chronic illness, and he's hoping that he'll be able to go back to work, if heart transplant is successful. He recalls that he received influenza vaccine and COVID-19 vaccine this past fall. The rest he cannot remember. No known exposure to TB, and some of the epidemiologic risk factor, at least in the US, that we ask is like homelessness, incarceration, long-term care facility stay, or living in an endemic area, of which he has not had any of those. So I think the principles of screening really depends on knowing what is the timeline of infection, whether it's solid organ transplant, hematopoietic stem cell transplant, and solid organ transplant. And for me, this is how I remember how to do screening rather than just memorizing. It's understanding the concept. So during the first month of transplant, after receiving induction immunosuppression and starting on some maintenance immunosuppression, T cells are not typically impacted yet. It takes a while before you try to really diminish their function. So during the first month of transplant, the common infections really attributed to their hospitalization, and rarely from donor-derived infection, which can be, viral, fungal. And this is considered a rare event, but it does happen, and one has to kind of really think about it when there is an infection that cannot be explained by the patient's history. And, patients who have underlying, infection that may not have been either diagnosed may also declare during this period. One of the concerns is always like strongyloidiasis, because these patients do get high dose methylprednisolone, and typically the donor also get a dose of steroids prior to the procurement, so which really increases the risk for dissemination. And in the US, it's going to be a standard now approach to actually screen for strongyloidiasis for both donor and recipient. So it's still undergoing some policy adjustment, but it's now a common practice because the mortality morbidity is significantly high. Now, after 1 month has passed, this is the period wherein the degree of immunosuppression really is at its peak, between 1 to 6 months. And the range is broad because it depends on the type of transplant, what is the immunosuppression protocol of the center. So in the United States, there is an emergence of using more alemtuzumab. In our center, we use it for lungs. We use it mostly for kidneys too. So those patients at a higher risk. But with the standard practice of prophylaxis for CMV, pneumocystis, we don't see a lot of the opportunistic infection related to PJP, herpes viruses. And the use of Bactrim obviously, help in reducing the risk for bacterial infection, including Listeria, nocardia, and parasitic infections such as toxoplasma. So other endemic infection that may emerge will depend on the exposure history of the patient, and we kind of like really strategize ahead of time if we think that may potentially be a reactivation. Now, more than 6 months, if all goes well and the immunosuppression has been tapered over 6 months, these patients still obviously at risk given their immunosuppression, but probably less for some opportunistic infection, and they are susceptible to what they are exposed in the community. Now, the immune system is very dynamic because the immunosuppression on this patient can always change at any point. If they develop an acute rejection, there is again an intensification of immunosuppression, and these patients fall back into that middle square between 1 to 6 months, and depends on the prevention strategy of this patient about regarding starting again the prophylaxis that you previously have given them during the early part of their transplantation, or you do preemptive monitoring for the CMV that we do by molecular by PCR. Because I'm not aware of what are the availability of some of this diagnostic testing, as I'm speaking from the Western experience. So this is just like kind of like a brief overview of the induction immunosuppression given for patients here in the US. Thymoglobulin, alemtuzumab. Alemtuzumab is more potent because it affects both B cells and T cells, and there is a lower or slower recovery of of T cells. Sometimes it can last for even a year. I have a patient who had CD4 count of less than 100, that lasted for a couple of years. So those patients, like, you actually have to decide whether they need longer course of prophylaxis, given that there is also some personalization in terms of mitigating the risk for infection. So basiliximab, is an IL-2 inhibitor. It inhibits IL-2 mediated activation of lymphocytes, and I would say probably less potent than some of these lymphocyte depleting agents. And these are the common maintenance immunosuppression. In the current era for calcineurin inhibitor, tacrolimus is the preferred one. And for the anti-metabolite, it's mycophenolate. Some do give prednisone depending on the protocol of the center. Typically, they avoid the prednisone just because of the risk of new onset diabetes after transplantation. And in some cases, mTOR is given because of its anti-cancer property. So in patients with known history of cancer, especially for our liver patients with HCC, they alter after a month the mycophenolate to sirolimus or everolimus. And in the US, when there is calcineurin inhibitor toxicity or tolerance or intolerance, they're switched to a fusion protein, belatacept, which is an intravenous given on a monthly basis. So this is what, the new kid on the block, and we're still understanding really the impact of this on their risk for infection. But I think with people using it more widely, the experience for long-term use is different from what they have observed in the clinical trial, which is a short-term observation. So cyclosporin azathioprine, we still see it in some patients, but this is like almost like the past era, but some patients are still maintained on that. So the purpose of the pre-transplant evaluation is to assess patients for active infection that may be a contraindication to transplant, to assess for prior infection and exposure that may potentially reactivate after transplant. And this is an opportunity to provide education and recommendation on safety living after transplantation. So this is a time to kind of really evaluate vaccines, lifestyle, job. And I think this is, for the most part, the most valuable thing. And I think one thing that we need, because Definitely, there's a lot of vaccine hesitancy in the United States, given that misinformation. And people don't realize that vaccines, still save lives. I think we're aware of that. I originally came from the Philippines, and with poor access to vaccines, you can see how life-threatening it is, especially to children. So with regards to evaluating for active infection, definitely there are certain infection. So active infections are not, equally the same. So there is some thoughtful evaluation with regards to risk versus benefit, and it's a case-to-case basis. For example, patient has I would say a bloodstream infection. So Staph aureus bacteremia will be treated a little bit differently from a gram-negative bacteremia. So second also is like the source. In this patient that I just mentioned with the driveline infection, so it's a chronic active infection. Really remove, heart transplant probably is the solution because you're removing the heart and all the devices. So that's what we call source control. So this has been well studied, and there are a lot of papers on this that those with driveline infection did as well those without a driveline infection. So it didn't impact patient and graft survival. Certain infection, obviously, that are uncontrolled is a contraindication. And as I mentioned, chronic infection is not an absolute contraindication when the transplant itself may actually provide the source control that you need. Now, the practice of giving antibiotics, for example, after taking out the LVAD may vary in centers because it's not really well studied. So some do, a couple of weeks of antibiotics after, surgery. And this practice has varied. I've not seen any consistency. So it depends on, really the culture of the center. In terms of latent infection in the United States, there's kind of emphasis, based on, what we know about, the exposure history of most immigrants. So latent TB infection is one of those that we evaluate by either doing interferon gamma release assay, which probably is the more common test rather than doing a skin test because of convenience. Chagas, because we have a huge Latino community, and strongyloidiasis, and it is endemic actually in the United States, especially in the Southeast area. With latent TB infection, treatment is relatively safe with close follow-up, because we have to be also cognizant that these patients are on multiple medication that may cause hepatotoxicity. Timing of treatments preferred pre-transplant, but not necessarily need to be completed because it can be started and then, continued through their transplant. One exception to this may be a liver transplant candidate, because we have to discuss with the hepatologist, their hepatic function, because some liver transplant candidates may be listed for transplant as a treatment for their hepatocellular cancer. So those patients are basically their hepatic function is normal. So they can tolerate, the LTBI treatment, in contrast to somebody who's decompensated related to metabolic or alcohol-related, liver disease. So, there is definitely heterogeneity in this patient, but that is a matter of discussion with the hepatologist. And, the guidelines have changed in the United States, INH rifampicin weekly for 3 months, or rifampin, for 3 months, or, is the preferred. So shorter is preferred just because of better adherence to the medication, and most likely they will be able to complete the treatment compared to the, to the older preferred agent, which is INH. But for the most part, rifampin is problematic, or the rifamycin in general, because of drug-drug interaction. So still, most of the patients still get INH because, especially if they have not completed their therapy pre-transplant, and you have to treat them through transplant, that INH is probably less problematic. Now, in endemic areas, so there is some literature of some of the practices outside of United States. For example, in South Korea, Thailand, and even Thailand, that they actually do not even screen, because it's expected, given the prevalence of tuberculosis, that most have latent TB infection. So some actually just preemptively treat them after transplant, regardless of knowing what's your tuberculin skin test, just because of the prevalence in the area. And that may be the case also in the Philippines, or, in India, which I would love to hear actually later, like, what is the practice for this? And actually that practice actually works well, because the rate of active TB after receiving latent TB prevention, latent TB treatment, is actually very low. So in the United States, we have some policy to follow. There is a governing body in the transplant which have listed this in the policy, and there's some expected must that both donor and candidate should be screened for. So definitely HIV. HIV is one of those, and the other herpes viruses and viral hepatitis. We have used a lot of nucleic acid testing, at least for our donors. For our candidates, still and only do a reflex nucleic acid test if they test for some of these viral hepatitis positive. West Nile virus is something that we actually screen for our living donor, but not for our candidates. And then parasitic screening includes Toxoplasma, Strongyloides, and T. krusei. Toxoplasma became a mandatory screening mandated by UNOS since 2017, because previously it's only relegated to the heart transplant candidate, but they realized that there has been some donor-derived transmission from other non-heart organ transplant, because most forgo Bactrim use, because Bactrim becomes the what they call this, always blamed for the leukopenia, for the renal function. So other anti-PJP prophylaxis is actually chosen, but obviously they are not good prophylaxis against toxoplasma. So it's important to know the serology, so we can decide on what alternatives in case they cannot tolerate the Bactrim or the trimethoprim sulfamethoxazole. T. krusei is still something that we do as a strategic approach, just because the rates of false positivity of the test, and obviously you go through the positive, to the negative, you kind of choose really the patients who are probably at higher risk. And if the initial screen is positive, we have to resend it to the lab again using a different assay, like a different type of test, just to confirm, whether the first test is truly a positive. So in the US, there's some commercial labs that do this. If they test positive, we just send it to the CDC, because the CDC has the capability of even doing both PCR and a different type of assay. Now, in the US, we screen for coccidioides if they live in areas endemic for it, and mostly if it's in the Arizona, Southern California. So this is not also something we, screen routinely for everyone. And for bacterial, I already mentioned tuberculosis, but syphilis is one of those that we actually screen for. And the strategy of screening the syphilis may vary from country to country, because even in in the US, the methodology of screening has changed over time based on some studies of the CDC. So we usually do the antibody testing and then default it to the RPR if positive. So one thing that has truly advanced over the last decade is expanding transplantation to certain patient population that were previously excluded, and that includes the HIV patient. So we have proven that using donor negative to recipient positive is safe and comparable to somebody who is a non-HIV um, transplant recipient. So for patients who are HIV, it is required that they should be well controlled with regards to their HIV. CD4 count should be above 200. There is an exception that for liver patient, we can accept a lower CD4 count of 100 just because of hypersplenism, as long as they don't have a history of opportunistic infection. Because in liver patients, they may be artificially look like their CD4 count is low, but if you look at their percentage, they really have adequate CD4. It's all pulled in the spleen. And these patients should have undetected HIV viral load. While receiving antiretroviral treatment, they also need to be adherent to their treatment. And no active opportunistic infection and malignancy. So moving forward, so with the screening comes also with mitigating risk for infection. So these are the standard vaccines that we recommend. That includes pneumococcal vaccine. So currently what we have in the US is PCV 20 and 21. The seasonal influenza vaccine, which we start like rolling out around September or October. And then Tdap, hepatitis A and B, depending on the screening serologies, if they're immune or not. For our kidney patient, most patients actually have been vaccinated because it's a requirement if they will be on dialysis. Zoster or varicella vaccine, depending on VCV serology. For the most part, because I deal with adults, they are already positive, so we recommend Shingrix or the recombinant zoster vaccine on this patient, regardless of age, because the indication for the general population is 50 and above. But there is now a change in the CDC ACIP guidelines that actually the age cutoff, it does not apply to patients who are going to be subjected to immunosuppression or immunosuppressed. And COVID-19, obviously, MMR is recommended if there is no evidence of immunity. So that's one thing also we add in our serology. So some of these are checking measles serology is not really mandated by the UNOS and OPTN in the United States, but most centers do this so that we can administer, if they are not immune, a live vaccine prior to transplant. And when we give a live vaccine, it has to be 4 weeks before the planned transplant. So it's important to really consult the transplant team to know like where the patient is in terms of their listing. Is this patient the one who's going to get offer in the next 4 weeks because they're sicker, or this is a patient that they expect, they're going to hang around for a year or two. So there needs to be some communication with the transplant team so that when we give the live vaccine, will not be in that conundrum of, that they receive an offer. So I think it's a disservice to the patient. So communication is key. RSV in the United States is actually recommended for 65 and above. And the recommendation with regards to patients who are immunosuppressed or be subjected to immunosuppression is based on the risk-benefit discussion of the provider with their patient. But the vaccine is safe. So, I recommend my patient, but the problem is in the United States, if not covered by insurance, they have to pay a huge money out of pocket. So I just, make sure that they're aware of that. If they're willing, or if they have money to say pay for the vaccine, and I would just like tell them to just go ahead and get it done. Now, for patients with asplenia, whether it's functional or anatomical, that they don't have a spleen, Hib and meningococcal vaccine is recommended. And I didn't mention the pneumococcal vaccine because that's implied that since it is recommended for everyone going for transplant. So these are the things that we go over with the patient, is knowing their job condition, because if all goes well in transplant, this patient wants to have some normalcy, go back to their former job. So it's important to know, the aspect of their job, because if somebody is a construction worker, they're going to be exposed to soil aerosolization. Then they have to, probably wait for a period of time where in their a lesser degree of immunosuppression and wear the protective gears, whether it's a mask, wearing thick gloves, because if they're going to be handling soil, dirty, obviously in an environment that is not considered sterile, then certain education needs to happen. Now, in terms of pet, I think people are divided about this, because some do recommend, like, get rid of your pets. For me, I think pets are kind of part of the family. So one thing I discuss with the patient is that another household member should take ownership, and they have to be aware or just take precautions of not getting scratched, bitten. So they can make the proper adjustments, to kind of reduce the risk for exposure to infections that are or bacteria that dogs, cats do have, or other pets, because it's not limited to dogs and cats. It's always interesting to actually hear from patients the different type of animals they do have. So I have to even name all kinds of animals that I can think of, because sometimes like it is not what do you call this, like too obvious for them to say, oh, I have a parrot. Well, that's considered a pet, because the risk of cryptococcal infection is there. Lifestyle hobbies, if they like outdoor activities, that's something we need to modify once they are subjected to immunosuppression. Vaccines we discuss. And I think one emphasis that I do is actually vaccination of household members based on their age and comorbidity, because they are the cocoon of protection, for the patient. Because the risk of actually acquisition of any infection will most likely happen in the house rather than a random encounter with a stranger. So this is something that we talk to the patient and the family, to reduce their risk for respiratory viral infection, which is rampant obviously during the fall and winter here in the US. And if travel is something that will happen eventually, we always remind them that they have to notify their transplant team or us, for any, advice on any of the travel vaccines and other prophylactic antibiotics too. Because one thing I tell patients, because like if they go to, for example, a travel clinic, typically they give azithromycin for prevention of that, for treatment of diarrhea, and we know that that has drug-drug interaction with tacrolimus, and access to kind of like hospital is something also I have to emphasize to the patient, that they probably need to stay close wherein there is access to hospital. So obviously tacrolimus level is not a common test, So that's why I always emphasize to the patient that they have to really inform their transplant team, because we have to give them an alternative, and the choice of antibiotic may differ depending on which part of the world they plan to visit. So moving on to a different immunosuppressed population is the stem cell transplant. So we have here a 24-year-old AML patient who is currently on remission and being evaluated for stem cell transplant. Patient is currently undergoing treatment for invasive pulmonary aspergillosis, responding based on radiographic imaging. And at that time, she's still neutropenic, but afebrile. And she's already had received like a couple of months of treatment with a triazole. She's a college graduate and lives with her parents and no pets. So I'm talking to a group of experts, so I'm sure you are all aware of the principles of stem cell transplant. Stem cell, involves either the bone marrow, peripheral blood stem cell, and umbilical cord blood, and then infused in a patient without an immune system, meaning they have already received some conditioning therapy that actually destroys the leukemia cells, and part of that is also eradicating their immune system. And by giving them the stem cell, we are rebuilding these patients with healthy immune cells. And this patient obviously takes time to build their cells. So within the 30 days, we expect some engraftment, which is the emergence of their neutrophils, followed by a recovery of their innate and adaptive immune system. So the period of this recovery of cells is the period of wherein they're at higher risk for infection. And another confounder is actually if they develop a graft versus host disease, because that means they will be on intensified immunosuppression. So that adds more to the complexity of potential infections that can happen. So in the allogenic stem cell, this is like the classic timeline of infection. I think people have used this diagram for most of the talks, because this has kind of stood that test of time. This is back in 2009. Not much has changed. So in the period of pre-engraftment, these patients are neutropenic and therefore at risk for infections we see in neutropenia, which includes bacterial infection related to their mucositis, and reactivation of herpes simplex. There are always at risk for respiratory and enteric viruses, and obviously mold infection and candida infection. Now, post-engraftment, this patient still has an impaired cellular and humoral immunity. So even though bacterial infection is still a common infection, this is also the period wherein they may experience opportunistic infections such as CMV, even EBV, post-transplant lymphoproliferative disease, other herpes viruses such as the HHV, and fungal always is in the background, and obviously PJP, since this patient had impaired T cell immunity. Now, in the late phase, which is considered after 100 days, for this patient still has some impairment of cellular and humoral immunity. I would say more so on the humoral immunity, and they're at higher risk for encapsulated bacteria, which covers pneumococcal, Hib, meningococcal. But in the US, pneumococcal is probably the more common, and the mortality of patients with chronic GVHD developing invasive pneumococcal pneumonia is as high as 20%. So it is recommended actually that this patient should probably on some antibacterial prophylaxis that's covered pneumococcal, and the choice of antibiotic depends on basically the resistance in the community. For the most part, in the US, amoxicillin is still used, but if they is still used despite the rising penicillin resistance. Herpes viruses, CMV, VCV, is still considered or possibly can reactivate. And then fungal infection still there, and PJP can still happen given the impairment in T cells. And some do actually measure some immune in a way function. I would say more of immune quantity, because even though you quantify IgG and CD4, we don't know the function, but that is basically our surrogate as of now. So, and certain centers have different practices. In my prior institution, they routinely check for CD4 count, IgG, to determine if there is some sort of immune reconstitution, and prophylaxis that they can probably stop. The autologous stem cell transplant are probably less at risk, given that this is their own cells and they get a less intense type of immunosuppression. But they are still at risk for certain infections related to neutropenia, as outlined here, and even post-engraftment, as listed here. So with evaluation of this patient, pharma screening history is still important. It's important to assess their presence for active infection, infectious disease exposures, prior infection that may have been treated, infections with their prior chemotherapy. So just like our patient with the invasive pulmonary aspergillosis, knowing where things are in terms of treatment, because this patient may need to be still continued on therapy, even though they have pulmonary aspergillosis or mold infection, and still neutropenic. Stem cell transplant offers actually some sort of treatment, because you expect that they will eventually engraft and then and be able to recover from an invasive fungal infection. So this is a matter of risk assessment of the clinician discussing with their hematologist, because it's a matter of planning of, or discussing about, planned conditioning therapy. It's good to also assess patient for other risk factors for infection, including prosthetic devices, if they have a cavitary lung disease, their travel history, or whether they have resided in areas of the world with endemic infection, because screening, you have to target probably screening depending on their exposure. And other parts of the social history, such as illicit drug use and travel. Now, it's important to plan with the team what is like the type intensity of prior, actually knowing their type and intensity of the prior chemotherapy or radiation therapy, status of their underlying cancer, and other immunosuppression, whether it's a low CD4 count, hypogammaglobulinemia, asplenia, or receipt of high-dose glucocorticoids for a relatively longer period of time. So this is a table that I actually got from UpToDate, which summarized what was in what we still consider the guideline, the one that I referred to a while ago, which is back in 2009, and not much has changed. Probably some addition is obviously the SARS-CoV-2 screening. So part of the screening involves, history taking, physical exam, dental evaluation, routine x-rays. But for the most part, a lot of these patients have already received tons of, probably underwent tons of imaging, including chest CT scan. So reviewing those prior imaging is as important as well. Checking for CMV, the viral hepatitis. And for the other herpes viruses, like VCV, HSV, EBV are important just because of assessing the need for prolonged acyclovir on these patients. HIV, HTLV is like plus minus. It's not routine. I think there's a lot of controversies also with the test itself, that there's some rate of false positivity, because then if we just routinely screen, it leads to further testing, because you have to really assess if they have been exposed to countries with high risk for HTLV transmission, syphilis testing. Galactomannan is like plus or minus. Some actually do it for kind of like baseline and preemptive monitoring while they are neutropenic, but not a common practice. Toxoplasma for allostem cell should be screened. So there is a plan for mitigation. Some patients may be able to take bath cream at some point, but some centers actually have done PCR testing because they have seen still some patient who develop breakthrough toxoplasma infection despite prophylaxis. Screening for TB is important. Now, screening for colonization for multi-drug resistant organism is not something that is standard. I think for most hospitals in the United States, it's common practice when they get hospitalized that they do get screening for VRE and Staph aureus or MRSA. And it is important to know their prior infections because if, for example, in the onset that they develop infection, you can now strategize, what empiric therapy they do need. Because if they were colonized with a multi-drug resistant organism, then probably piperacillin tazobactam may not work. So this patient, can really decompensate so quickly that, the empiric choice of antibiotics do matter. SARS-CoV-2 screening is something that routinely most do when this patient actually enter the, what we call the BMT unit or the hem-onc unit. And other screening for endemic infections should be targeted as listed here. So in terms of vaccination, emphasis is more on the post when there is a return of immune competence, and vaccination strategy really depends on the age and comorbidity of the patient. So there was a guideline published here in 2013 in IDSA. And I think, and for the most part, that still holds true. Obviously, COVID is not listed here. There is a more recent version of vaccine guidelines that is published by the National Cancer Center Network. So this was early last year. And they have a recommendation here of the timing after stem cell transplant. For the most part, most of the vaccines are preferred to be given at around 6 months because at that point they expect like immune recurrence, immune reconstitution, and some require multiple doses because basically you have to train again your immune system because all presence of immunity that they had prior to transplant may have been eradicated. So live vaccine is something that has to be timed. They should be at least 24 months out. For the most part, they also need to, not for the most part, but they also have to be not on any form of GVHD treatment because obviously a live vaccine is contraindicated in that situation. So focusing on COVID-19, so patient who have undergone stem cell transplant or CAR T cell should receive one or more dose of the COVID-19 prior to or during treatment, should be revaccinated. And revaccination should start at least 3 months. So this is the kind of like the more forgiving in a way that you can do it much earlier just because of the prevalence now of COVID. So the things like you don't have to wait until 6 months down the line because if, for example, especially during this time of the year in the US, during fall and winter, much higher risk that you can offer this earlier than the 6 months. So case 3, moving on to actually CAR T cell, it's a 34-year-old male with known history of diffuse large B-cell lymphoma, previously received R-CHOP. And Patient is undergoing evaluation for CAR T cell, had viral upper respiratory tract infection, pneumonia, no recent hospitalization, and asymptomatic. So this is actually a great review by from the Fred Hutch, who has who is like, which is like one of the biggest cancer center in the United States. And I encourage everyone to actually, read this. They have a great how I, prevent or how I treat like series in Blood journal. Um, and there's a lot of infectious disease topics there. So in CAR T cell, so the risk of infection is kind of divided in three phases, which is like the theme of even of the prior groups that I have discussed. So in phase one, most of these patients really experience, some toxicities, um, related to neutropenia or the inflammatory treatment if they develop CRS, receiving steroids and tocilizumab. Um, and during COVID, we have given a lot of tocilizumab in my prior institution, and we have even seen cases of strongyloidiasis. Whether it's the tocilizumab or the steroids, it's like, it's hard to figure out. But, it's a lesson to be learned that it's important to assess these patients, like, endemic exposure. And that patient lived, I think, in an endemic area for strongyloides. So we are screening this patient, carefully. So these patients are at risk for bacteremia, gastroenteritis, and pneumonia, and herpes viruses, candidemia, and mold in a setting of, prolonged neutropenia. And this patient developed like impaired cellular and humoral immunity. So, and mainly the hypogammaglobulinemia is really, really impactful, wherein these patients are at risk for encapsulated organisms, respiratory viral infection, even PJP, and prophylaxis should be actually strategized. Oops. And there are certain patients who have really prolonged hypogammaglobulinemia, B cell aplasia, and this is wherein adjustment in the preventative strategy should be made. So screening that is recommended or the practice in UWASH is assessing for their HIV status, hepatitis B, hepatitis C, and the rest are kind of just a consider. But I think for most centers, they screen for this because of planning for their prophylaxis. So this is actually a great diagram showing what is the practice or choice of prophylaxis. So in the setting, obviously, of neutropenia, antibacterial prophylaxis, levofloxacin is somehow the practice because it's a once-a-day medication, easy to take for the patient. Acyclovir or valacyclovir for herpes virus prevention, fluconazole or micafungin, because this patient may not necessarily have prolonged neutropenia but at risk for candidemia, and trimethoprim sulfamethoxazole if there is a significant concern for severe hypogammaglobulinemia or T cell dysfunction. And in terms of antimicrobial management and infection monitoring in case they have CRS, empiric broad spectrum antibiotics, according to the fever and neutropenia guidelines of the institute. ID consultation is recommended to help with either escalation or de-escalation of patients who are considered high risk. I know I'm running out of time, so there is a list here that actually classifies which patients are considered high risk. And mentioning one of those is like patients who have received high dose steroids or tocilizumab. So in terms of screening for certain viruses like hepatitis B, if the patient is a known chronic infection, documented by either Hep B surface antigen positive or detectable HBV DNA, entecavir is recommended. And then for those who are core plus, it's some do monitoring of both hepatitis B and liver function tests, or some just like, by default just give entecavir, because there may be a chance that certain patients may not be able to get their routine blood test. So I think just to kind of like prevent a potential complication is like giving these patients like entecavir, similar to somebody who had a chronic infection. For chronic hepatitis C, recommended referral to a specialist. I think that depends on the country where you're practicing. I think Hep C treatment is now easier than it used to be. That in the US, even some primary care doctors are doing this, at least for patients who does not have any evidence of chronic liver disease. And then HIV needs all assistance from the infectious diseases. And I think the reason also is like also assessing drug-drug interaction. Even though we are now using integrase-based inhibitor, which does not have any drug-drug interaction, there are still some patients who are on protease inhibitor or NNRTI that can potentially interact with some of other medications. Now, I think I received this in one of the questions regarding immunoglobulin. So these patients, do get some routine immunoglobulin just to assess, their immune reconstitution. But in the setting of low immunoglobulin levels, it is encouraged that they should be replaced, especially if it's less than 400, which is considered a severe hypogammaglobulinemia. And then in 400 to 600, also consider, especially in patients with had serious or recurrent infection related to encapsulated organism. And then there are 600. This is wherein like it has, it's a risk-benefit thing that one has to consider, and maybe also need assessment of other immune markers such as total IgG, IgM, IgA, their B cell count, and their IgG for strep pneumoniae, serotype, and tetanus and diphtheria. And I think based on that, kind of decide if truly it's important to replace. Because immunoglobulin 2 is not also kind of benign. Some do get, the reaction. And I had a patient who actually developed, almost like a, kind of fluid overload type of presentation after the immunoglobulin. So it's not completely benign. Now, vaccination timing for somebody who had received CAR T cell for inactivated vaccine should be 6 months at least post CAR T cell, and 2 months since the last immunoglobulin treatment. Because I'm looking at this for any reference on this, but I think there is that, what is cited in most papers, like there is that theoretical kind of decreased response to the vaccine. So that's why it needs to be spaced out. Now, for live and non-live adjuvant vaccine, it is preferred to give it 1 year post CAR T cell. Now, there are certain contraindication, and obviously if they don't meet the criteria, essentially. So this is a vaccine strategy for those who had no prior vaccines or have completed post stem cell transplant vaccines. And if they're 6 months away, is to vaccinate and then check titers if it's available and decide whether you need to revaccinate or not. Those who have prior stem cell or did not complete post stem cell vaccine, then you have to vaccinate these patients based on the criteria we have listed and complete the series. If there has been no evidence of response by checking the titers, there are also other immune markers that you can check to assess that if you need to give additional doses. You know, I know there's a mention of chemotherapy, but chemotherapy is so very heterogeneous. I think I just highlighted rituximab because that's the really representative of the B cell depleting agent, which really puts patient at risk for a lot of the viral infection or even bacterial infection. But the recommendation when I look across, even for patients with rheumatologic disease, these patients are recommended to be screened for hepatitis B, HIV, and latent TB and strong giardiasis depends on the exposure history. In terms of vaccine, should be considered at least 6 months after completion B cell depleting therapy. Now, if this patient goes through like a cycle of like rituximab exposure, then vaccine should be administered somewhere in the window of like 4 weeks before the subsequent scheduled therapy. Now, to protect our immunocompromised patient, I highly emphasize on vaccination of household members, but there are some certain caveats that we have to keep in mind about certain vaccines that may actually be, can potentially impact our immunocompromise. And this had to do with the live vaccine because some of the live vaccine can shed. You can have, for example, varicella vaccine that can cause skin lesion and can, result to a transmission. So I will, because we're running out of time, so please refer to the 2013 IDSA guidelines for vaccine. And actually, what is good about that paper is that it covers all immunocompromised hosts. So it expands even to patients with common variable immune deficiency or patients who are receiving treatment for rheumatologic diseases. So in summary, risk assessment is important. Some risks are standard, and some risk depends on exposure history. And risk may differ. Risk for infection may differ across this patient population depending on the degree or type of immunosuppression. Epidemiologic exposure, I keep emphasizing this because, for you all practicing in India, you are more familiar than I do in terms of what's endemic. It should be considered. And so your screening and disease prevention may differ from, other parts of the world. So I end here. So thank you again to the organizers for giving me the privilege to share what I know in terms of screening practices.
Thank you so much, ma'am. Wow, that was very, very comprehensive. So while listening to you, I can just give you an update. More than 310 people have listened through the webinar mode, and more than 100 people have been watching you on YouTube. So it was a very comprehensive webinar, ma'am. Thank you so
Oh,
much for that. Yeah. In the due paucity of time, actually, majority of the questions which I was intending to ask, you have already covered that. But I need two queries, ma'am, which usually come to our mind. That one very important thing is considering antibacterial prophylaxis, especially in the hematopoietic stem cell group, or for that matter, the CART group, and the other immunotherapies, considering we are now entering or almost entered into the zone of multi-drug resistance. And second thing, that since we are more TB endemic country, so it's always a hitch to use fluoroquinolones upfront as an antimicrobial prophylaxis for the majority of the patients. So any comments that any studies or any idea about or any experience to share that, because we nowadays relatively lesser use the antibiotic prophylaxis and more try to test for active infection. So any comment on that?
Yeah, I think it's challenging, in the era of multi-drug resistant organism. Like, how do you actually prophylax this patient, knowing what is the epidemiology in your country? I think one thing that and I may be wrong, kind of thinking in a way we're in, our gut is full of bacteria, right? Because with neutropenia, really it's the risk of mucositis and translocation of this bacteria somewhere else. And I don't think there will be a consensus and say what would be the perfect antibiotics to completely prevent 100% any type of bacterial complication, right? And with antibacterial use also, it's like a whack-a-mole, like you prevent, certain, then something else will emerge. I would say like, for mucositis, still the more common is like streptococcal infection. I think at least in the United States with quinolone use, we have not seen a lot of like gram-negative emergence. It's really more gram-positive. So I think it's important to study what is your observation in your country, and truly, is there a need for really a more broad spectrum? Because there is also the complications with that, right? Are we increasing our risk for emergence of more MDROs, the risk for C. diff infection in these patients? So I think it's a tough, it's a real conundrum, but also there is no ideal solution, I would say, to the situation. And I think it's important to study also, the experience, centers across your country to say, because it is obviously different from the experience in the United States. But I think, you know, you know, antimicrobial resistance is truly the new, what we call, it's an epidemic. And I think pipeline is not as robust as we want it to be. So stewardship is important in, implementing in this challenging population. Because, we do interact with different subspecialties, and it's always like broader is always better, and sometimes that's not the case. So a lot of education of our partners in taking care of our patients, because it is not a problem that's going to go away, but I think with judicious use of antibiotics, we might turn the whole narrative in a different way. So
Right, ma'am.
I may not have given you an exact answer.
So that's the true thing, because there is no exact answer, as you mentioned very clearly. So what we have started doing is, since of course we need to save more on the fluoroquinolones, as I anticipated the risks in terms of resistance. So we have started doing kind of piloting, especially in DMT patients, because they are more prone. So we have started doing the rectal surveillance testing pre-transplant, and in few patients who have had the more risk of developing more MDR bugs, we have started doing a fecal microbiota transplant scan for them to decolonize the gut. Although it's a very trivial experience in my center, we have done so far in 5. But luckily, in amongst those 5, in 3, we were able to actually prevent those sepsis in there. So,
Yeah.
I mean, it's still in a very, very baby primitive mode for us. So,
Yeah. So in my prior institution, in the solid organ transplant realm, determining colonization with multi-drug resistant organism is not a common practice. But, at Yale, we have screened for non-candida albicans, we have screened for VRE, and that is not a common practice. But at least it helps us to say, kind of like, the patient doesn't need daptomycin. The patient doesn't, and we're able to get away just using fluconazole in these patients if they're considered high risk for candidemia without using micafungin, because we know that, in candida also species, there is also now emerging resistance to some, to a lot of our antifungal agents. So, and I think everyone is developing their strategy on how we can protect our patients, from overexposure to unnecessary antibiotics. So there is some personalization needed, but I think there's still a lot of room to actually study that aspect of the care of the patient. And I think your experience, I think you should, you should publish it, because, I'm sure that there are other parts of the world also encountering, issues with MDRO, and what preventative strategies we can offer these patients.
sure. Thank you, ma'am. That's the really inspirational for me too. That's great. And then just one last question, ma'am. So about the CMV prophylaxis, when we were discussing even in the before we started the session,
Mm-hmm.
obviously the letermovir has become a very good drug of choice in both the HSCT and SOT. Have taken a
Mm-hmm.
lot of our grievances and thought process. Of course, we have a very limited accessibility to letermovir for sure.
Mm-hmm.
Though we are lucky enough that we have tried in 8 of our patients and they were absolutely went very hale and hearty without any breakthrough. But
Mm-hmm.
any other alternative agents which we have tried apart from the existing letermovir, say a double dose valcyclovir or the acyclovir, or any experience or a touch upon on that now?
Yeah, so the data is really kind of obviously supports, the use of valsite, for SOT. In BMT, obviously letermovir changed the game because valsite is not something that, stem cell transplant recipients can tolerate because of the leukopenia. And the data shows that there is really an improved mortality outcome for these patients. So in the US, if they cannot tolerate any of the treatments, you know by default the recommendation is preemptive monitoring, meaning we do weekly CMV PCR on this patient and then treat them, you know, depending on the threshold, whether it's D plus R minus in SOT, R plus. So threshold of when to treat has not been fully established. And I think that depends on the clinical experience. Like when do for D plus R minus, like any level in SOT, you just treat. For the R plus, the practice varies. And for the stem cell, previously, when they cannot be on the Val site, is that, really the standard practice then is preemptive monitoring. But PCR is not as widely as available. I think I just had the privilege of being in an institution that, be able to do it routinely. But there is also some downfall because, these are patients that needs to have like really routine monitoring weekly, and if the patient missed it, then you may not have identified that there is viral replication, that you could have actually started treatment sooner. And because before you know it, they have CMV disease. There are other agents, but we do not use them routinely because obviously there is, like maribavir is there, but it's really meant for refractory um or resistant CMV to ganciclovir. So it's not something that we kind of like, use as a default if they cannot afford, letermovir, um, or cannot tolerate valsite. And obviously there is a cost also to the maribavir. In the US, if the insurance doesn't cover it, it becomes challenging. So I think, if patient cannot be on either CMV prevention strategy of valsite and the thermovir, really the next best recommendation, at least in the Western world, is preemptive monitoring, and then treat, depending on the patient's risk for CMV disease.
Right, ma'am. Because we usually follow the latter half, because considering the limited availability of letermovir and majority of the elderly patients, when there is due to the renal modification, there is a lot of times dose changes in the valacyclovir group as well. So we do also prefer the weekly CFV PCR based monitoring and treatment accordingly. Right,
Yeah.
ma'am.
Yeah.
I think there are no more questions in the chat box since it has already covered as we discussed in the queries. So I think if no more questions, on the behalf of the team Fortis and on the behalf of Infectious Diseases Department at Fortis, it's a really great and honor to be with you, ma'am, and listening to you. Some great concepts about the infection screening in immunocompromised hosts. And thank you so much for presenting that such an enlightening seminar for us. Thank you so much.
Okay. Thank you.
Thank you, ma'am. And I hand it over to the MCure team.